And then one other announcement. So the MARC, the Minority and Allied Residents Council, is starting up for this year. So they're a group of residents and fellows from across all of our campuses to support minority residents and foster allyship. So if you are interested in joining, please feel free to scan the QR code. They also have a welcome picnic on the 15th. So if you're interested, please RSVP to them. They have the 2 QR codes up. Great organization to get involved with. Questions on that? Okay, let's jump in to our case. So to start us off, we have an 80-year-old male. He's had a recent MI and 2 prior strokes, complicated by residual left-sided weakness, who's brought in by his son and daughter because they're not able to care for him at home anymore. He was recently at a rehab facility after his strokes. And since getting discharged and coming home, the family has just said, we can't take care of him. It's too much work. We're going to bring him back here. He, particularly with his past strokes, he can't walk more than a step or 2 on his own. He has some pretty significant left-sided deficits. He hasn't had any infectious symptoms, but basically was discharged from rehab. And after a couple days at home, they realized, hey, we cannot do this on our own. So you can see his past medical history there. He's had his 2 CVAs. He's had a recent MI, history of alcohol use, but he's been sober for the last 10 years. Hypertension, hyperlipidemia, hypothyroidism. Family dropped him off and talked to the ER, but they were actually gone by the time the admitting resident came by. So we don't know the medications he's on yet. In terms of his social history, he does live with his wife. She's pretty sick too. She has diabetes and sarcoid. Previous trucker. And then for his family history, his mom was very old when she passed. She died of natural causes, had diabetes. And then his father passed away of a stroke. Any questions or things that you guys want to know more about from his history? Not acutely sick. They just couldn't take care of him anymore. And so they brought him back to the VA. Okay, let's get into his vital signs. So in the ER, his vital signs are only notable for some borderline hypotension, normal heart rate, normal temperature. He's standing fine on room air. And then in terms of his physical exam, you guys can see some of the neuro and MSK deficits from his prior strokes. So just so you guys have a baseline. But otherwise, he's not acutely ill as he comes into the ER. So he's admitted overnight, tucked away. The overnight resident puts in some basic orders for him. Who here has ever admitted a patient where the primary concern is maybe placement for the family? Plus the seniors raising their hands, some of the interns too. Okay, so talk amongst your table and figure out in the next 30 seconds, what are the basic orders you'd put in to work up this patient who's not acutely ill coming to you to help set him up for success for the daytime team to start the ball on his clinical course. Let's take about.
To clarify, this issue with walking is
not new. It's he can't walk because of the deficits from his stroke.
Got it. Wanted to make sure this is correct.
No, perfect question. All right, so take about 30 seconds and I'll ask each table, what's one thing that you would order to get the ball rolling on this guy's admission? Okay, so I'm gonna start on the left side of the room. Patient's table. Do you guys have anything that you would order for this patient who is not acutely ill, getting admitted because family can't take care of him? Things you'd order, things you'd ask for. Perfect, getting an accurate med list. Okay, basic labs, sounds good. Table 2 here, anything that you guys would order or ask for? PT and OT. Okay, figuring out if there's maybe more services that we can offer him. And then last table, anything that you guys would do? A PVR, so seeing if he's having maybe some urinary retention. Who would want to ask more questions about why they can't take care of him at home? All of you, right? So our psych colleagues often do a better job of gathering collateral than we do. So we'll get his basic labs. We don't have any recent labs in our system because he's been hospitalized at various other facilities for the last couple of years. But otherwise, the only grossly abnormal things for him. So he's a little bit anemic, a little hypokalemic. That creatinine's a little high, but we don't know what it is with regards to his baseline. And then this T-billy is also a little bit elevated. We do eventually, yep.
What is that lesion on his forehead? Like this, does it look like an injury?
Yeah, he had like a scratch on his forehead, but no trauma that was reported from him or from his nursing home. He might have. We don't really have any additional information about that. Okay, so let's go down to his medication list. So just based on his history, you guys probably could have anticipated some of these medications. So he's on aspirin, atorvastatin, given his recent MI, carvedilol, and clopidogrel, a diclofenac gel, and then he's put on enoxaparin for DVT prophylaxis in the hospital, fluoxetine, and gabapentin as other meds. So you guys talk to the family, you do a great job of gathering that extra collateral, and his daughter says, he got discharged from rehab, he's home with me now, and I'm having such a hard time taking care of him because he can't really use the left side of his body. He can't get up and transfer by himself out of his chair. And he is having significant diarrhea every day. And I just can't clean up after him and take care of him with these bowel movements that he's having. She also notes that he's lost about 15 pounds in the last couple months. And when you go back through the data that you have, you see that in the last about 18 months, he's lost 60 pounds. Granted, he's been pretty sick with these strokes and these MIs, in and out of rehab, but these are the family's main concerns. Any questions on that? How long has the diarrhea been going on? So it's been going on for months. They can't quantify and say exactly when it started, but he's had it for the last couple months. Jessica? He had it a couple years ago. It was normal. Great questions. Who here has a great way that they think about chronic diarrhea? You feel like you have an algorithm, you're like, I know exactly what to ask and what to do. I'm a pro when it comes to this. Not seeing many hands, okay. So hopefully you guys learned something from this conference today. Let's talk about diarrhea. How do you guys define it? Anybody can shout out a definition.
Osmotic.
Okay, so a type of diarrhea, perfect. But how do we define diarrhea itself? There is a number. Yes, 5. Any other guesses? 3? Yeah. So it's more than 3 bowel movements in a 24-hour period. And then what's the time course between acute and chronic?
1 month.
Perfect. Who said that? You? Okay, great. 1 month.
If it's right.
1 month for chronic diarrhea. You'll also find that some organizations will say that diarrhea is not just loose stools, but it can be like increase in urgency, increase in frequency, in addition to actually having those 3 bowel movements a day. Questions on the definition? We're pretty comfortable with that. It's
So
pretty,
there's no textural aspect of the definition.
it's just loose stool. So some organizations will use that Bristol stool chart. I think 5 to 7 is considered diarrhea, according to them. All right. And so Anne had said osmotic as a way to describe diarrhea. What are some other categories of diarrhea that you guys know of? Secretory, osmotic, inflammatory, bloody. Yeah, great. Explosive. Okay. So, we're gonna go through as a group because I think that for the most part, we're pretty bad at coming up with a structured way to think about chronic diarrhea. So we're gonna walk through this chart together. You guys are gonna do some group work. So I heard infectious as one of the causes. So take a couple minutes with the folks at your table, and I'm gonna ask table 3 down here, Ben's table, to start off by giving me some causes. I'll move to this middle table for what the typical HPI would be for a patient coming in with that. And then the last table can talk about exams. We'll talk as a group about labs and other tests to work up diarrhea. But let's start off with infectious. So take about 2 minutes and talk with your teams, and then we'll come back together and fill it out for this first one.
Yes.
You were quick on there. I was
All right, so let's get back together. So for infectious diarrhea, table 3, what are some causes that you guys thought of?
Thought of a lot.
Okay.
Just not the whole list, and just kind of look back to
Sure, and do you guys know which one is most common for an infectious diarrhea? Yeah, so it can be viral. You think about things like noro. You said bacterial. What's the one thing that we worry about here in the hospital? Perfect. And then parasitic, was that the other one that you mentioned? Okay. Of your bacterial infections, which one is going to cause a chronic diarrhea? I heard someone talk about it. I think Gabby was mentioning it.
don't know what I said, so.
So
Disease, which would be unusual.
true. So Giardia can cause a chronic diarrhea. That's like the one infectious cause to think of. Middle table, how would someone present if they had diarrhea to an infectious cause? What would be the typical story?
Maybe some kind of exposure recently, whether it's to skin contacts, antibiotic use.
Perfect.
Something weird.
Yeah, I love it. So Connor hits the nail on the head. There's going to be some sort of exposure. So whether it's antibiotics for C. diff, travel, eating some sort of food that was bad, but exposure is the big thing. And then it's usually an acute incident. So it's not like been brewing for a couple weeks. Last thing on exam, anything in particular you would look for would help guide your diagnosis?
I think it's more like diffuse tenderness, like that, or like a.
Okay.
Kind of anger.
Yeah, perfect. So a pretty non-specific exam, maybe some diffuse abdominal tenderness. And then what are some labs that you guys would check to work it up? So GI PCR. What else did you say, Noah? Stool O and P. What's the one we send most commonly here in the hospital? Perfect. And then the rest of your testing can really be based off of their specific travel history. If they're immunocompromised, you may need to do more specific testing. What are some other diagnostic tests you could ask for? Yep, so stool culture. Stool leukocytes, did I hear that? Okay. Maybe I'm not asking this the perfect way, but for other tests, we could do things like colonoscopy with biopsy. So if you have an immunocompromised host, you might need to biopsy to look for things like C and B colitis. If they're like a BMT patient, maybe you are biopsying to look for cord colitis if they had their transplant from a cord. Okay, let's move on to the next one. So I heard inflammatory.
I have a question.
Yeah.
So you said Diarrhea would be chronic, but then they would still present with the acute, like this happening. And it's chronic because despite treatment would go on for a while or?
So usually for Giardia, the exposure is like you went hiking, you drank some water that was, fresh water from a river or something. And it can last for a long time if it's not treated. So people can come in and say, I went hiking, I had diarrhea since, haven't been seen by a medical provider, and then that might guide your workup for that. Okay, so inflammatory, we're going to do the same thing. We'll start at table 1 to think about causes, and then we'll come back down through the tables again. So take about a minute and a half to talk about causes of inflammatory diarrhea, and then how they would present, what test you do, and then we'll regroup. Okay, so we're gonna keep moving along. So table 1, do you want to start us off? Okay, so table 1, causes of an inflammatory diarrhea. What's on your mind? Yep, Crohn's, UC, perfect. What are other things that could cause it? Celiac? I can start flushing them. Perfect. So lymphocytic or microscopic colitis. Okay, table 2. What's the story going to be? What kind of bowel movements are they going to be having? Yes, so usually bloody. Great. And then someone mentioned associated with rheumatologic conditions. What are other things they might talk about that's bothering them when you're examining them or taking their history? Yep, joints. Skin complaints, perfect. Okay. And then will family history be important here? Could be, right? All right, table 3, exam. We've already mentioned a little bit of this. So anything else that you would look at? Yeah. So we'll examine their skin. We'll look at their joints. You guys will go find your ophthalmoscope, look in their eyes. To continue with this table, what labs would you order? All the autoimmune stuff. What are some basic labs that you can order? Perfect. Yes. And then what are the other tests that you're going to be calling people for or asking about? Yep, so they're going to need a colonoscopy for sure with biopsy to make sure we can actually diagnose whatever their condition is. Okay, the last 2 that we have, osmotic and secretory. Do you guys feel like you have a good understanding of the difference between the 2? Seeing some yeses, some nos. Anybody want to take a crack at defining the 2 of these?
Isn't osmotic more like things in your intestines pulling water out of your body into your stool?
Yeah.
And then secretory is the opposite.
Yep, so osmotic diarrhea, you're ingesting something that your body can't absorb or take in. So that's this little chain of, let's say carbohydrates, if you're lactose intolerant, pulls water in, it can't be absorbed. There's an X where it would be absorbed. Secretory, you are overproducing their various electrolytes. Those get pulled into the GI tract and then water follows them. So it's usually a problem of electrolyte metabolism or a disorder regarding that. Okay.
Hunter, could I
Yeah,
chime in with something real quick?
sure.
A little bit of read my mind, but when you have someone with Crohn's or UC, is there any infection that you guys know is infamous for causing flares of ulcerative colitis or Crohn's disease that we all have in the hospital? C. diff. So when you have a person in the hospital with UC or Crohn's, flare, make sure you test them for C. diff. It's a really common thing we see all the time.
Okay, so let's get that out of the way. Read a great description of the 2 of those. So let's talk about osmotic and secretory. We can do this together as a group. So starting with osmotic, what are some things that can cause an osmotic diarrhea?
I'd say that too.
Yes. Yep, so laxatives, if people have like carbohydrate intolerances, so they're drinking milk and they're lactose intolerant. Okay, and then what's the story that someone's going to tell you if they have an osmotic diarrhea? So think about like lactose intolerance. Yep, so large volume, watery stools, worse after eating. If they fasted, does it get better or worse? Gets better. So watery, large volume, and better with fasting.
Osmotic diarrhea, is it typically more urgent than other types? Like you feel like the onset of it? I'm just thinking of your lactose intolerance.
It can be true with other types too, so like inflammatory diarrheas. People will feel like a lot of urgency to go to the bathroom. So not specific. Any specific exam findings that you guys would look for? Nothing really, right? And then what are some labs that you can send off to work up an osmotic diarrhea? Perfect, stool osms. Great. And then any other special tests? So if someone is like lactose intolerant, you can send them off for like a lactose testing or whatever specific to their intolerance, but otherwise nothing specific that you're going to ask or send off for. Jumping down to secretory, our last kind of diarrhea. What's going to cause that? So we're producing electrolytes that aren't supposed to be there.
Like, as far as like going through some of the zebras first, but this is like your like the gastroma, things like that. Kind of shell
Yep.
step one.
So various tumors, VIPomas, gastronomas, your Zollinger syndrome. What else can cause this? Cholera is going to be infectious, right? It can, but it would fall into the infectious category for our.
Consider like how do you? I feel like when I'm trying to categorize celiac, it's like it's part malabsorptive and part inflammatory and part secretory.
Yeah, so for celiac, I kind of consider it its own thing.
Yeah.
Because there's a definitive test or a good test that we have for it. So I don't usually put it into one of the others. But for secretory, there's sort of a sister of that. So like bile acid, malabsorption. And then other systemic causes. So like hyperthyroidism, Addison's, or adrenal insufficiency can all cause it. So just to be quick here, so they're also going to have watery stools. Do you think that they're going to get better if they fast? No, because it's usually a systemic process. So it does not get better with fasting. Would your physical exam help you differentiate between any of those causes?
They have that weird thing that on the rash.
Yeah, so maybe they have like a weird rash. What are some symptoms of like hyperthyroidism that you might pick up if that was the cause? Yep. Exophthalmos, a goiter, maybe they're tachycardic, diaphoretic. What about if they had adrenal insufficiency? Yep, so maybe they have tan skin, they might have orthostatic vital signs, maybe they're salt craving. Perfect. What labs are you going to send off for these folks? A BMP, then maybe the stool osms again, right? And then what other testing is going to differentiate these like weird causes for us?
Stool electrolytes?
Yep, that's what the stool osm / electrolytes. One more time. Yep. So TSH, we want to check an AM cortisol, right? If we're worried about AI. And then any other specific testing that we could do, special tests or other invasive things?
It's like a last test, like a exocrine.
Yeah.
Deficiency test.
Yep. Pancreatic elastase. Perfect, Noah. All right, and then you can check all those weird tumor markers if you think that's something of interest. Okay, so we reviewed those causes of diarrhea. You should also have like a secondary thing that you think about in terms of your red flag symptoms to call GI when someone's having diarrhea. Any thoughts on what those red flag symptoms are?
Weight loss.
Yeah, weight loss, blood.
Waking you up at night.
Yep, if the diarrhea is bad enough to wake you up at night. So number doesn't really matter. What about age?
New onset after 50 generally is no bueno.
Perfect, great. So there's other things for you all to keep in the back of your mind. Anytime you have these alarm symptoms, so onset after age 50, if they're having any sort of blood, like Ann said, nocturnal pain or nocturnal diarrhea that's waking them up. If they're having systemic symptoms, weight loss, fever, any severe lab abnormalities, or if they have a family history of IBD, without them having a personal history or a family history of colorectal cancer, you still want to call GI and get them involved. Okay. Do you guys feel like you have a little bit of a better way to organize chronic diarrhea now? Okay, so let's go back to our case. So we chatted, with the daughter, and she was like, yeah, this guy's diarrhea is just unmanageable at home. So day one of his hospitalization, they get an abdominal X-ray. They decide to hold his bowel regimen. He was getting quite a bit of stuff at his nursing home. Anybody want to walk us through the abnormalities on this KUB? I'll give you the iPad and the pencil. You can just sort of draw through what you think is abnormal.
Something that is very wide.
Yeah, you want to point out your data? So go ahead and draw out the wide area that you see. Okay.
So I don't know if that's his colon. I think it might be, and it's very large.
Yeah, great. And is that the only one that you guys see?
Some other large.
There's a lot, right? This is like a pretty wide area. This is wide. You have something wide back there. Okay. So can you guys see that blue line, or is that not quite dark enough?
Yeah.
Okay. So not normal, right? So you get this. When you go to examine him, he's a little bit distended. He's not having any nausea. He's not having any emesis. He's still having pretty profound diarrhea. You see all of these very large dilated loops of bowel. What's going to be your next test that you order? Yeah. So let's see what his CT scan shows. And so I will play this and loop it for you guys once or twice. Oh. Okay, we'll do one more time so that way you guys take a second look. Whenever I look at abdominal CTs and I want to follow the bowel, I actually usually start at the rectum and work my way backwards because it's usually easier to track the colon as opposed to the small intestine. So that's one tip for you guys. So this is grossly abnormal, right? Big, large, dilated loops of bowel. He's got fluid levels in his bowel. And then did anybody notice if there was a clear transition point?
I could not find one.
Okay. Let me get to a good cut. So I would say about here, you can see that there are some areas of bowel, like this is the beginning of his small intestine. That's pretty narrow, normal caliber compared to his colon there, which is extremely large and dilated. So what are you gonna do when you get back this CAT scan? Call someone? Okay, call Gen Surge, make them NPO. What diagnosis are we worried about? One more time. Toxic megacolon, that occurs with what condition? Okay, do you want to maybe check a C. diff first? We did. His C. diff is negative. He is having continued nausea. Now he's having emesis, he's having diarrhea. We had that scan. Saying make him NPO. Claire wants to put in an NG tube. All those things happen. He gets some fluid back in his NG tube, but there's not significant output. And his diarrhea is still persisting during this time. So he's NPO, he's got the NG tube in, he's still having some big bowel movements. We've now checked a C. diff. What other labs do you guys want to check, or who do you want to call?
I just from that CT scan, did they have diffuse bowel wall thing in your colon, or or is it just like dilated?
Just dilated. So if you look here, that's like a pretty thin wall. Same thing up here, it's very thin. So it's just dilated bowel. There's no bowel thickening.
And the CT scan did demonstrate a clear transition point?
No transition point on that. So let me give you guys his read. Let's see if I have that final read from. Okay, I don't have the reading here, but there's no transition point, just dilated loops of bowel. Okay, so what consults are you going to call? Just because we didn't see a transition point on imaging, does that mean that we've answered that question? No. So what's going to be the diagnostic test to rule out some sort of stricture or? So we can do barium study, colonoscopy.
He's too scary.
So surprisingly, he was not too scared for colonoscopy. GI was actually willing to entertain that. So we're going to call GI and say, hey, can you maybe scope this guy? We know he's not visibly obstructed because there's no transition point on his CT scan. He's producing diarrhea and his nausea is well controlled now with this NG tube in. Are there any other services that you would call in a patient with possible bowel obstruction? Surgery. So surgery is consulted, they follow along and they're like, yep, you're doing all the right things, you know, nothing more for us to add here. So let's go to hospital day 3. So we consult GI, they do a colonoscopy. What do you guys think they find?
Cancer.
Cancer, nothing. Angry mucosa. Ben's right, they find nothing. So he gets scoped with GI. His mucosa looks fine. They even take biopsies to look for lymphocytic colitis, like Anna had mentioned, possible inflammatory condition. He's been taking some aspirin that can be associated with it. Biopsy is negative for any sort of microscopic colitis. What do we do from here?
Just go from above.
He did not get an EVD, but he got a colonoscopy.
Did they look at neuro biopsy?
No nerve biopsy specifically. They just took about 5 or 6 different biopsies from his colon, but everything looks normal in there. Ovalbees, what's that?
It's like a wall, it's like talking medical one, that's like, with no like etiology for it. And it's like everything else has been ruled out, basically, there's no no obstruction.
Yeah, perfect. So ovalbees or pseudocolonic obstruction is a condition that can happen where the patient is presenting as if they have a bowel obstruction, but there's no actual mechanical force in there to cause an obstruction. There's something in his history that puts him at risk for this. So he had a recent stroke. It can be very common after that. Also common after surgical procedures, specifically like abdominal procedures or GYN procedures. Obviously, he's not having any GYN procedures. And then, do you guys know how we manage ovalbees? Neostigmine. Yep, there's a small trial. What are the other things that we do for supportive care? So we're not just going to be like, oh, push the neostigmine, call it a day. He already has some of them going on. NG tube, bowel rest. So you don't feed them. You give the colon a chance to sort of relax and start working. Unfortunately, he couldn't get neostigmine because his MI was about 5 months ago, and that's a contraindication to receiving neostigmine. So he did not get that. And meanwhile, he's still having all of this diarrhea.
I mean, that's the interesting thing is that like usually with colonic pseudo obstruction, you don't see.
It's usually constipation.
Belly pain. You get that same X-ray, looks like that, but they have the descendant painful back with no output. So it's a little bit strange.
But bowel rest sounds like a great plan anyway,
Mhm.
because we need to rule out with it, so that it's triggering him for it.
Yeah, so So he's been in PO and he's still having large volume stools, like 700 mils at a time.
And have a big bulk, a loss in weight, right?
Yep, yeah. Should we revisit our chart and maybe think through some other labs that we want to order? Okay, so do we think that he has an infectious diarrhea? We did check for C. diff, that was negative. Anything else that you guys would want to check for?
I mean, Giardia, did that come back positive?
So he did have a test for Giardia. It was negative. As a reminder, his potassium was 3 when he came in. It hung out around there for most of his hospitalization.
And because we posted the colonoscopy came back negative, inflammatory, and like.
Yeah, so he probably doesn't have an infectious cause. C. diff negative, Giardia negative, inflammatory. We took biopsies, looks good.
Because it's not laxatives, he's a PO and it's only.
Yeah, so osmotic is unlikely as well, but what can we check to sort of, yeah, perfect, stool osms. So let's sneak this way and I will give you guys his stool osms. So do you guys remember how to calculate? Put it up there because I certainly did not remember all of those. Okay. And then if I recall, his fecal sodium was about 20. Fecal K was, I believe, 125. So anybody want to plug into their MD Calc? Yeah, 290 is used as the baseline. Zero? Okay, so his gap was 0. Do you guys know how to interpret or which numbers we look for? So for osmotic, your stool osm gap is usually greater than 100. And for secretory, it's usually less than 50. So where does he fall? Secretory. Okay. Are there any other things that you guys would want to check in terms of labs before we start jump into a very expensive workup?
His meds.
Check his meds. Okay. He was on aspirin, statin, beta blocker, clopidogrel, fluoxetine, and gabapentin. Someone said TSH. His TSH was 3. So fairly normal. He's on a stable dose of levothyroxine. His AM cortisol was also normal. How do we test for celiac? Yeah. And what else do you have to check when you're checking a TTG? Perfect. So his IgA was 395. His TTG is less than 2, both of which are normal. So what do? We just say, sorry, you have diarrhea. We're not really sure why. We'll get you into a nursing home and call it a day. We did have a pancreatic elastase. He had a history of alcohol use, so maybe, he had some pancreatic insufficiency. It's 259, normal as anything greater than 200. So he's also good on that front.
Did we talk about his diet?
He eats a regular diet, nothing out of control.
He has lactose intolerance, but we did have taste testing.
So he's been able to eat milk and drink, all that stuff without any issue for his whole life. What'd someone say? Okay, what is a CA19 going to tell us? Does he have any evidence of pancreatic cancer? Okay, he just has diarrhea. So at this point on, during his hospitalization, we were all sort of stuck as well. So we sent off all this workup. It all came back negative. We empirically treated him for SIBO. or small intestine bacterial overgrowth. So he has a history of diabetes, which could put him at risk for that. Anybody know the treatment offhand? So actually rifaximin. Rifaximin, can't spell. And so he still didn't even get better with that. So what would you guys do if you had worked through that entire chart and nothing had really come back? Would you guys start a workup for all those weird things that Carl mentioned?
Yeah.
Do you guys know what tests to order? Okay, get a VIP level. What are some other ones? Let me
What's
check.
sensitive is like the chromogran. They'll just tell you if it's like any of those.
VIP, chromogranin. Any others that you guys have heard of?
They do gastrin and then they do urinary serotonin or 5H. IAA. whatever it is.
Perfect. You can do urine and serum of those. Okay, and then for these weird tumors, let's sort of break them up into categories. We have our VIPomas, we have our gastrinomas, and then you have your carcinoid. What's like the textbook patient for each of these? Okay, gastrinoma. Okay.
No, it's okay.
So a gastrinoma produces excess gastrin. So what sort of symptoms would they complain about with that? Stomach ulcers, yep. So they're gonna have new PUD or GERD. And then what about your carcinoids? Yeah, so that classic flushing, maybe they have a new murmur. Great. Okay, do you guys want to figure out what happened to this guy? All right, so we get some labs back. And we had ordered a couple of these early on in his stay when his diarrhea was refractory. And his VIP level came back at 96, which feels high for a test that I don't order that often. And it was. So got a repeat test and it was still around 70. So anytime a level comes back elevated, you always want to double check it before you start this massive workup for a patient. It may lead to nowhere. So we rechecked and it was still high. What do we do next to work up a possible VIPoma?
Probably some nuke med scan you can do. I don't know which one.
Yeah, there is a nuke med scan that you can do. And so
Is it accurate? That's the one that I know.
he went down for a nuke med scan and he basically gets this radio tracer injected into him and it's taken up by some organs naturally. So you can see here that the liver and the kidneys are bright because they take up the tracer. Does everything else look normal?
It's very bright.
No, so this area here is extremely bright. And so when the radiologist went and looked at his nuke med scan and compared it to his CAT scan, that localized to the area of his duodenum. So they're concerned that this patient had a possible VIPoma in his duodenum. What do we have to do to confirm that? Biopsy. He wouldn't let us. He was tired of being in the hospital and having medical procedures done. But we were convinced enough by all of his studies that he did have indeed a VIPoma causing his chronic diarrhea. Do you guys know how we treat that? Yeah. So a little information on staging. So you can follow the normal TNM staging like many other cancers. Obviously for him, there was no other evidence of metastatic disease. In terms of nodal disease, we didn't see any lymph nodes light up. It was just his duodenum. Couldn't get an exact size because he wouldn't let us biopsy his site of his tumor. For management, you want to address their volume status. So these patients can become profoundly dehydrated with how much diarrhea they're having. And then, like Dante mentioned, hypokalemia is the hallmark of VIPoma. So we aggressively repleted his lights. In terms of management, you start them on a somatostatin analog. So octreotide is short acting, lanreotide is long acting, and he was on both of those medications at some point in his treatment. And then obviously for treatment, most of these tumors arise in the pancreas. You can do a pancreatectomy to treat them. He obviously was not interested in that given his comorbid conditions. And median survival is pretty good, so 96 months, and it all depends on the initial staging of the patient. So this was an actual patient that we had here at the VA, my intern year. He came in just for placement and quote unquote failure to thrive, but had an actual problem, this chronic diarrhea that was preventing him from being cared for at home. Got started on these somatostatin analogs. I was doing pretty well up until recently. I just checked his chart again, and it seems like he actually had ovalbees syndrome, they think from his treatment. And so he ended up getting a colectomy in the end to deal with that. But he's doing well, 3.5 years later on these medications. He's a pretty older guy to start with.
But he never had a resection.
He never had a resection. He didn't want any more medical therapy after that. So today we talked about a framework to work up chronic diarrhea. We talked about the 4 different kinds. We talked about the lab test that we'd order. We talked about how to progress through a workup for a patient with chronic diarrhea. We reviewed alarm symptoms for anyone who would call GI definitely for some sort of scope. And we also reviewed the diagnosis of ovalbees and the management of that.
So do you think he had ovalbees?
He may have had ovalbees on top of this VIPoma.
It seems like it's just all the thing about it is where ovalbees usually it's a struggle. I guess in this case, it's just sort of like you're trying everything, but I don't know. I've never processed ovalbees with like alpha.
Yeah.
So.
And I think it's actually pretty, it's a higher percentage of patients that have diarrhea than one would think with ovalbees. Like up to 20% of patients with ovalbees will have diarrhea instead of constipation.
Like just obstruction present with diarrhea, right?
True. Yeah. So if someone has like a big stool ball, very common, like in kids, for example, your pediatric patients, but always good in older adults to double check that too. So that's why he had that KUB and then the scan to see if there's anything obstructing. But okay. Any questions on this case? Okay, great job, guys. I hope that you have a better framework for chronic diarrhea. Tomorrow we have M&M, so we'll broadcast from the U. Wednesday, Dr. Connors is coming for an ICU case, so please be present. And then we'll have regular conference the rest of the week.